Hi, my name is Anthony Effinger. I'm here at the Think Neuro podcast, and today I'm interviewing Dr. Dan Kelly. He's a neurosurgeon and the founder of Pacific Neuroscience Institute. Thanks for sitting down with me today.
Hi, Anthony.
How are you?
I'm good. How are you doing?
Good. Great. Thanks for making yourself available.
Sure.
So I want to know, just to start off, tell me a little bit about your practice.
So my practice is neurosurgical practice. My focus is really in brain tumors, all types of brain tumors, so from the benign to the malignant. And that encompasses a wide spectrum of diagnoses. Patients come in with all sorts of different neurological complaints. Occasionally they're discovered incidentally. Someone may get a scan for, say, a headache, and they discover an abnormality, and then they come to us. In many of those cases, we just reassure them that there's nothing that needs to be done other than follow it with regular scans. But occasionally someone gets a serendipitous scan and they end up having to have surgery.
Oh my. When did you know you were going to be a neurosurgeon?
Not too long ago, actually. It wasn't planned, actually. In some instances, people plan for years and years to think about it. But I came to it in sort of a slow, very, very methodical, in some ways haphazard process, I suppose. In high school, I was very interested in the biological sciences. In college, I got extremely interested in the neurosciences and actually the evolution of human intelligence. And as I was thinking about what to do, I was also actually interested in marine biology, and was thinking about going and getting a PhD in marine biology. And ultimately, I decided to go to med school to sort of postpone a decision. I thought there were so many opportunities in med school, that I would find something that I really would gravitate to, and I kept coming back to the neurosciences and to surgery. And neurology, although a wonderful field, very diagnostically oriented, lots of great tools and technology, but I really like the hands-on and the sort of athleticism and art of surgery. And given where we are in terms of neurosurgical advances, I thought that was really an area where I could be stimulated and creative for a long time and be challenged. And so it became over time through med school more and more clear that neurosurgery would be the way to go. You
said athleticism. I think it really is. It's a feat of.
Yeah, you can't be a total klutz. You have to have some decent hand-eye coordination. You have to have a certain amount of finesse. You have to have a certain patience is really key, and you have to do a lot of training. You have to and have some endurance. Because a lot of our procedures are quite long.
How long?
Well, a typical brain tumor operation is anywhere from 3 to 6 hours, but then some go 8 to 10 or 12 hours.
Oh my!
And so you need the ability to maintain focus and to remember what's critical and keep the goals of the operation in mind. One of the big things also is sort of the decision making. How far do you go? Because a lot of times we deal with tumors that are perhaps very stuck or adherent to blood vessels or critical nerves or the brain itself, and you have to decide when to stop. If you leave a lot of tumor behind, that may impact the patient negatively. But if you go for broke, so to speak, if you really try to take everything out, you can end up hurting patients. You can wind up with a stroke. You can wind up with impaired vision that they didn't have. So it's a very fine line, and that decision making is key, and you have to sort of maintain your sharpness throughout an operation, so that you don't veer off into an area where you shouldn't have gone.
Were you always good with your hands? Was this?
I did a lot of sports when I was younger. I skied a lot. I played tennis a lot. I actually wrestled. in junior
Valuable for
high.
neurosurgery.
I was a county champion at 76 pounds.
Fantastic.
In 8th grade in Arapahoe County in a suburb of Denver. You being from Colorado. Well,
Yeah, know it well.
that.
Yeah.
So yeah, I did a lot of I did a fair amount of sports, and not overly committed, but it was a part of my life. I played tennis 1 year in college at Claremont.
So you have a history of athleticism.
Yeah.
Yeah. And how was it for you training as a neurosurgeon? Is it as rigorous and demanding? And
Yeah, I trained. I went to med school at Georgetown, and then I did my training at GW from 86 until 93. And, the training is such that you initially, this was back in the days when there was no resident hour rules. And so
of course.
call was really, you spent a lot of time in the hospital. And we would do stints where we were on every other night call.
Oh my God.
Which would be fairly exhausting, and there was a lot of sleep deprivation. And but I liked it. I mean, I really enjoyed it. I mean, there were days where you just couldn't believe you were getting, your beeper was going off again, at 2 a.m, at 4 a.m, and this just interrupted sleep day after day, and probably not great for you, but that's the way training is, or certainly the way training was. And I think the thing about training is that I found that people that were really kind of thriving and into it had realistic expectations. The people that didn't have realistic expectations, that they were going to maybe be able to go home and kind of live their life, they weren't very happy.
So you knew this was going to be like boot camp for...
Yeah. I mean, I think most people understand that. And so, but training is a very interesting process. They say, see one, do one, teach one. I mean, that sort of phrase is true to some degree. And it's a very hands-on, very raw experience. Being at trauma centers, I was you see a lot of amazing kind of horrific stuff and some really beautiful stuff, people having amazing outcomes. So the training and the neurosciences, particularly neurosurgery in general, there's this incredible spectrum of pathology and people going through some really, really tough stuff, and then some really amazing outcomes.
Do you remember your first neurosurgery?
I remember one attending at GW who was a real kind of classic jerk in the operating room. He was a jerk to everyone. He was very condescending. He did stuff that today he would be off the medical staff in a week.
Abusive?
Yeah, abusive to the nurses, but an incredibly good surgeon. Very thoughtful, and I learned a lot from the guy. I didn't learn his behavior.
Yeah.
I didn't pick that up. But I remember doing my first craniotomy with him, and
That means
taking some bone away from the head, to get in and remove a tumor. I believe we were doing that, and he didn't like the way I was holding an instrument, and just gave me a super hard time for that. This is like my first year so my second year of training after my surgical internship, and then doing my first year. And he was hard on everyone, but that's you kind of get used to that.
I bet you never held it that way again.
No, I didn't. Yeah.
Then how long did you practice before you became interested in the pituitary gland?
Well, that started when I was a resident, largely due to my mentorship with Ed Laws, who is still practicing. Wonderful guy, father figure to me in a lot of ways. Just an amazing man, perhaps the biggest name on the planet in pituitary surgery. And he was also the editor of one of the neurosurgical journals. Back then it was called the Red Journal. And he just a wonderful mind, brilliant, kind of a Renaissance man. And he really got me excited about the pituitary gland and pituitary tumors, and I just thought that it was such a fascinating area. I mean, it's really at the intersection of the mind and the body. You know, being the master gland, it controls all the body's hormones, and it's so small and so delicate, and in this space that's surrounded by all these critical structures, including the carotid arteries, the optic nerves, the brainstem, and yet it's accessible through the nose. Imagine that.
I was looking at a diagram of the brain and where the pituitary lives. It's like the crossroads of every important thing in your body, right? And it's the size of a pea. Is that correct?
Yeah, just about.
Yeah.
Lima bean, maybe.
On a good day.
On a good day, yeah.
So what goes wrong with the pituitary that we need to fix surgically?
So the pituitary gland is a site of many tumors, benign tumors, what we call pituitary adenomas, and they're actually the third most common intracranial tumor, behind meningiomas, which is a benign tumor, and gliomas.
Okay.
And pituitary tumors are number 3. And so there's a lot of patients develop adenomas, and they can cause they typically cause pituitary gland hormonal dysfunction. Either they produce too many hormones, so you get an excess, say, of cortisol in your body, or an excess of growth hormone, or an excess of prolactin, and those are all individual syndromes. As they get bigger, they cause what we call symptoms of mass effect. So as the tumor gets bigger, it compresses the normal gland, and so you can get loss of pituitary gland function. The gland can fail, so you can develop all those things like low thyroid, low testosterone. Their periods can stop. They can become, men or women can become infertile.
And this is because this is the master gland. It controls so many other things.
So as it's growing,
you mess with this.
Yeah, the outflow signals, the hormones that are supposed to be being sent out by the pituitary gland, they stop, or they go to such low levels you become symptomatic and you develop these pituitary insufficiencies or deficiencies. So the other two things that can happen is you can get vision loss, because as the tumors grow, they grow upward and they hit the optic chiasm directly above the pituitary gland. So a classic syndrome of an enlarging pituitary adenoma is what we call a bitemporal visual field defect, meaning where you lose your peripheral vision because the fibers that are hit classically are in the midline where the nerves cross, and that's where your peripheral vision in each eye, that data gets transferred back to your occipital lobe back here.
Right.
So vision loss of pituitary gland function, and then headaches. And headaches are very common. There's sort of a typical type of a pituitary headache where people usually say it's in the front of the head, above the nose here, kind of, or above the eyes. That's kind of the classic pituitary type headache. So it causes those symptoms of mass effect: headache, loss of vision, pituitary gland dysfunction, and then there's the overproduction of what we call the endocrine active pituitary adenomas, where they're making too much of something.
Is an adenoma malignant or non-malignant?
They're benign.
Okay, they're benign.
They're almost all benign.
But they're in the way.
They're in the way, and some of them are bad actors. So there are what they used to call atypical pituitary adenomas. They've reclassified them, but there's a subset of pituitary adenomas they don't really behave like a cancer, but they're aggressive and they're more invasive. They can get out around, say, the carotid artery. They can get out around the cranial nerves that move the eye into this area called the cavernous sinus. Even some of the very benign ones can be invasive. They're invading into that space, and so they're very benign, slow growing, but they're in places where we can't get them all. So then they may need not only surgery, they may need radiation, or in some instances other treatments.
Is there anything that predisposes somebody? Do we know anything about the causes?
No.
It's just
as far as we can tell. Yeah, there are some cases associated with prior radiation. People have had radiation, but that's pretty rare. And radiation-induced tumors in the head tend to be things more like meningiomas, occasionally gliomas, other types of
Not these necessarily.
Not.
Okay,
not
so
much.
what do you do then? Somebody comes in, they've presented with this headache or something else like that. You've scanned them. They have
A pituitary tumor.
yeah.
And so, if they come in and they have vision loss and they have a large tumor, say that needs removal, then we remove it.
Is it always a surgical solution in this case, or you said that sometimes it's not?
So for all of the pituitary adenomas except one type, if it's symptomatic, the first line treatment is endonasal endoscopic removal.
Endonasal through the
nose with an endoscope.
Okay.
Yeah, surgical telescope using both nostrils. And the goal is
one for one.
So we have the endoscope in one nostril,
Okay.
and then we have instruments working through both nostrils. And the anatomy of the nose is such that if you remove a little bit of the back of the septum, way in the back that's not structurally significant, and you open what are called the sphenoid ostia, there's two openings into the sphenoid sinus, which is an air sinus behind the nasal cavity and right up against the pituitary gland. If you remove the back of the septum and you make those two openings into one bigger opening, then you have this big working corridor, relatively big.
I was going to
to
say
work through.
Yeah, what's big for you?
Well, a 4 millimeter endoscope
okay.
is the diameter of this high definition, beautiful, surgical telescope, and then we have these very low profile instruments that are working through both nostrils, and the two surgeons are looking at the monitors. It's team surgery.
Why is that?
Well, because you have to have someone drive the endoscope. Back in the day, we did, and I did it that way for many years, with an operating microscope. So the operating microscope came into neurosurgery in the 60s, and it really changed neurosurgery in a wonderful way because you could see things better than, say, with a headlamp. As you can imagine, that this fine structures that we need to see.
Yeah.
So the surgical microscope was a huge advent, but in the 90s, people started using endoscopes.
You're talking about a camera on the end of a
stick.
Yeah.
Yeah.
Is the stick bendy?
Well, there are flexible endoscopes,
okay.
but the optics are so much better with the rigid endoscopes,
okay.
and they lend themselves very well to endonasal surgery that we use only the rigid endoscopes.
Is that because it's a straight shot?
It's a straight shot from the nose to the base of the skull.
Okay.
And now, because of the advent of endoscopy and a number of other things, we can address and remove a whole variety of tumors that are in or around the pituitary gland and all around the skull base, from low down to high up. And so there's a whole spectrum of midline, what we call midline brain tumors, that we can remove through the nose now. And that's been one of the biggest changes in the last 20 years. This advent of endoscopic
because before
skull-based surgery.
When you talked about what did you call the microscope?
Mm-hmm.
How did you can't get that into where the pituitary is?
You can't put the microscope in, but you can imagine if you put a speculum in the nose, in a nostril. Or you used to do it under the lip. It was called a sublabial approach. So you can go in through this opening. If you look at a skull, you can see what's called the piriform aperture. So if your nose is cartilage and skin. So the old approach was to make an incision just above the incisors here and open up into this mucosa. If you put a speculum in, you push the septum to one side. You can get all the way back to the skull base and to the pituitary gland. And that was the way it was done forever. That's the way Harvey Cushing did it. So through the piriform aperture, that's what this is called. And going back, you can imagine this is where the pituitary gland lives right here, and the optic nerves are coming out here, and the carotid arteries are coming up along the side here. So it's a very, very busy, high-rent district.
High rent.
But this really, revolutionized pituitary surgery, so using an operating microscope. But then starting in the mid to late 90s, we started using endoscopes, and we certainly weren't the first to do it. There were a number of pioneers in this area, and the endoscopic approach over time has really won over, simply because you can see better. Yeah. And as optics have gotten better and we have high definition scopes, the view we get with the endoscope is amazing. And so, but to be facile and to be two-handed neurosurgeons, someone has to drive the scope.
Yep.
And then someone has to operate. So the paradigm now, the way we do this now, is we have two surgeons. My ENT partner is Dr. Chester Griffiths, who's fantastic and a wonderful surgeon. And so the majority of the cases that we do with our pituitary team, my partner, Dr. Barkadarian, is using this what we call a fully endoscopic approach. For many years, I was using an endoscope-assisted approach. We'd start with the microscope, and then we'd switch over to the endoscope. We would, and actually for brain tumor surgery, which we may talk about later, is we often do endoscope-assisted approaches. We start with a microscope, and then we bring the endoscope in to look around corners. And the beauty of the endoscope is not only is it high definition, up close view, it allows you with an angled lens to look around corners. So you can see things that you couldn't otherwise see, and it allows you to do a lot of stuff without retracting the brain. So we've applied a lot of endoscopy techniques into intracranial brain tumor surgery. And that's one of the things that we're really known for here at PNI, and one of the things that we've really pushed the envelope on. But suffice it to say, this approach through the nose with an endoscope using both nostrils, no incisions on the face, is the way we remove 99% of all pituitary adenomas, and the way we remove the vast majority of a bunch of other tumors that can occur anywhere in the midline here.
Okay.
And the reason we can't go too far off the midline is because we have structures like the carotid arteries and the optic nerves where it's safer and better to come from above through a different approach.
Now, do you take turns? Does one surgeon drive sometimes and one person?
Yes.
Really?
Yeah, but the ear, nose, and throat surgeon, we don't like to let them get close to the brain. No, the reality is that the ENT or the otolaryngologist will drive the scope. They're really a key member of the team because they do the approach. What do you
mean do the approach? They do the actual. They get you in there.
Get us there. Okay, yes,
right.
And that's also an area where we've really pushed the envelope on being very careful not to disturb the normal anatomy. The old approaches with the endoscope, and still in many places, they I would say they're not necessarily very gentle on some of the tissues, and the rates of people losing their sense of smell and other issues related to removing tissue become significant problems for the patients postoperatively. So we do a technique, a sort of an incisional technique, where we simply incise the mucosa. We want to be extremely careful to preserve olfaction, the sense of smell, and we know where the olfactory fibers are coming down. And so we are very careful with the way the cuts are made. We're very careful with the blood vessel supply. And so it's sort of almost like in a series of incisions and drapes where you push everything out of the way. Then we remove the bone that we need to.
The bone in the
at the back of the nasal cavity.
And it's that's small.
It's pretty small. And then and doing all that it certainly requires finesse and skill, and that's what Dr. Griffiths does and his colleagues, Dr. Karimi and Dr. Pierce. But that approach, then getting us there is really a key part. And then once we get inside the sphenoid sinus, we do the exposure over the pituitary gland or wherever the tumor is, and then we go in and take the tumor out.
How do you get when you're in there, you see the tumor, right? And you're like, okay, how do you get it out?
I can't tell you.
That's the trade secret?
Yes.
Okay.
For pituitary adenomas, the distinction between the normal gland and the adenoma is usually pretty clear. We pay a lot of attention to the MRI before surgery, so we do. Patients will get a high quality, high definition MRI of the pituitary gland, and it will show how the tumor is related to the normal gland and where it is in relation to the carotid arteries and the optic nerves. And so all that data we use, obviously, when we go in, and we know where to find it. And then when we remove the bone in front of the gland, then we open the dura. Before we do that, we always listen for the carotid arteries because we want to make sure we don't injure the carotid arteries as we're opening the dura, which is a very well-known complication of this surgery. So the Doppler probe is very helpful for helping us know exactly where
The
they are.
Doppler probe is a listening device.
Yeah, it's
that's
like a long.
inside.
It's on a long, flexible tip, and we also use navigation. It's like GPS for the brain. So we have a probe that will tell us where we are. The problem is the navigation is based off of the CT scan or the MRI, and it can be off by a few millimeters. So the Doppler probe, in terms of localizing the carotid artery, in our opinion, is much more accurate in real time.
Yeah.
So because we can put it and we can direct it, and it'll tell us exactly where it is, and it allows us to do a very wide but safe opening of the dura, that covering to the brain and the pituitary. And then in many, if not most instances, the tumor we'll be looking at the tumor. It'll be right there, and maybe the gland is sort of like a crescent moon or like the peel of an orange. And so then we go in with a variety of little micro instruments, and we peel the tumor away from the gland. For the large tumors, we will tend to remove sort of the lower half of the tumor first to take the pressure off of the optic nerves and the surrounding structures. And then we do a sort of a dissection around the capsule of the tumor and pull it away from the gland, being very gentle on the gland, with the goal being a total removal and protecting the gland and actually improving the function of the gland by taking the pressure away from it.
So the material from the tumor comes out. You take that out of the body.
We have a variety of little grasping, tumor grasping forceps or biopsy forceps. We gently pull the tumor away from the normal structures. It all comes out. And sometimes it goes up the suction, of course. Yeah, we have suction to keep the blood out of the way. And
that suction's in there as well.
Absolutely.
There's a lot of instruments are going
so
in
usually,
through this.
So you have the endoscope in one nostril. You have a suction in one nostril, and then you have a working instrument in the other. There's always a suction there because there's always oozing and bleeding going on and fluid, and we have to irrigate. We have to irrigate with saline to kind of flush the blood away to help us see better. And very important to keep you can't keep a, quote, a bloodless field, but you want to keep as much blood out of the field as possible because it actually absorbs the light and it makes your endoscopic view much darker.
What's in your hands when you're doing this?
I'm holding instruments. So it could be a micro scissor. It could be something called a ring curette, which is what we use to dissect the tumor away from the gland.
So what is keyhole surgery?
Keyhole surgery is a term that we use to describe this minimally invasive approach with less collateral damage to the key structures, really starting on the outside from the scalp, the muscle, the bone, the covering to the brain, and then ultimately, of course, to the cranial nerves, the blood vessels that supply the brain, and the brain itself. And so it's using these minimally invasive approaches through typically smaller openings to essentially sneak in and sneak out, remove a tumor with as completely as possible without causing any harm. And so we have developed all these approaches over time, and I say we, the collective we, the people that are really kind of pushing this minimally invasive movement in neurosurgery. And the approaches that we use are through the nose that we've talked about quite a bit, the endoscopic endonasal approach, the supraorbital eyebrow craniotomy, the retromastoid approach, and these gravity-assisted approaches. And all of those allow us to get to places that you could get to, and in many places they do, with a more traditional, larger craniotomy. And we've really been pushing this with, using the endoscope, using low-profile instrumentation, using navigation. And as you do these more and more, doing pituitary surgery for many, many years through the nose, you get used to working in a very small space. Yeah. And you just don't need much room. And the traditional skull-based approaches, which are still taught and talked about a lot.
I was going to ask, what percentage of people are pursuing the minimally invasive keyhole techniques?
I'd say it's more and more people are doing it. Is it common practice? No, because I see referrals all the time coming from some of our, local institutions here. where they're getting recommended these very traditional big approaches. And it frankly surprises me. Those approaches are still being taught at a lot of the training programs. They're discussed at meetings, but there's this other side. There's a bunch of us doing this and pushing the envelope on this. So
What year did you start doing minimally invasive keyhole?
There's not some point where we just started doing it. I mean, I've been pushing it for 20 plus years, and we've gotten, I would say we've learned a lot. We've gotten much better. We've published a lot. Yeah. We use these keyhole approaches for the vast majority of all the brain tumors we take care of now, and I'm including pituitary tumors. So the vast majority do not require, in our opinion, a big traditional craniotomy.
But it sounds like other people are still doing these big traditional craniotomies?
Oh, yes.
Really?
A lot of them, yes.
So people are getting big holes put in their head to get these things removed.
And in many instances, the operations go very, very well. In our opinion, this is a better way to do it. It's patients they get a great tumor resection with less brain retraction, in many instances with less collateral damage, and they're out of the hospital very quickly.
How quickly? What are we talking about?
So the average is 2 days, but sometimes it's the day after surgery. And
2 days for brain surgery.
Mm-hmm. Yeah, the majority of our patients with a benign brain tumor, if you take pituitary adenomas or meningiomas, are going home in 2 days. Yeah, and some go home in 1 day.
The day after surgery, you go home.
Got to take it easy.
Don't go out and don't go surfing the next day. Say, yeah. What is the recovery? I mean, how long are you sort of?
So we typically tell people you take it easy the first week. Plenty of walking is good.
Okay.
Nothing too strenuous. You can be a little more active the second week. You can drive after 2 weeks, and after 3 weeks, you can do anything.
Really?
Yeah.
Do you have to change your cognitive, like reading, any of that? Is that all? It's not like a concussion. You know how they warn people now not to.
No, but it really depends on what you have, what kind of tumor you have, and how you were doing beforehand.
Okay. I can't believe that's what we're, because the less time in the hospital is the better, right? These days? Okay.
Absolutely.
So you were at UCLA, and tell me how you came to start Pacific Neuroscience Institute.
So I came in 2007 after a couple of years of considering my options and seeing a great opportunity at the John Wayne Cancer Institute, which was actually part of UCLA until 1991 when the entire institute moved over to St. John's. It was front page LA Times News. Apparently. So in 2007, I finally moved over to the John Wayne with the idea of starting a brain tumor program and a neuro-oncology program. And I came by myself, but was colleagues with Howard Krause and Chester Griffiths. And over time, we worked together. I brought in a junior partner, Garni Barkadarian. Chester and Howard's practice grew. And we saw the need and the opportunity to build a bigger program. And we wanted our own neuro-oncology division, neuro-oncologist, and so we recruited Santosh Kesari, who's one of the other 4 founders, who I'm sure you'll talk to at some point. And so we recruited Santosh from UC San Diego in 2015, and as that happened, we started to conceptualize the idea of Pacific Neuroscience Institute and expanding into these other areas. We're starting to work with George Teitelbaum, who's one of our neurointerventionalists, to develop a stroke program. And so we also saw that we were doing a lot of stuff that was not necessarily brain tumor related and cancer related. And we felt the need to develop a new institute. So that's how Pacific Neuroscience Institute started. So it really sort of budded off of the John Wayne in a way. And we're still all part of the John Wayne and those of us that are doing tumor work. But the institute now has 8 clinical centers of excellence and a research center. We have over 30 MDs. We have a bunch of PhDs. We do a lot of clinical trials. We do fellowship training. And our institutes now, our centers of excellence now really cover the full spectrum of neuroscience disorders. So not only, tumors, but stroke, hydrocephalus, facial pain, movement disorders, and most recently, brain health, which I think is going to be one of the most interesting.
What's in there? What's in?
So within brain health, the initial big focus has been on dementia and cognitive issues, but we're also expanding into other things like anxiety and depression and addiction. We're building a program in psychedelic assisted therapies. There's a huge renaissance going on in psychedelics right now, particularly with psilocybin and MDMA, and we're going to be part of those.
That's fantastic.
Clinical trials, and we feel that. That's just a really important for any neuroscience entity to be involved in. I think that this area of psychedelic assisted therapies is potentially the most interesting and impactful area of the neurosciences right now. It has great potential to totally transform behavioral health care because there's just so many people that are impacted with anxiety, depression, addiction, PTSD, and the current therapies simply, they work, but they're not great. And I think there was so much good science being done back in the 50s and 60s and early 70s, and it all got buried for the reasons we all know. But fortunately, it's coming back, and we're going to be part of that.
So how do you like having an institute with everybody in one building or very close to each other, and you got all this expertise? Does that help you do your specialty?
Absolutely.
Yeah, that's fantastic. I thank you so much for your time. It's been a delight. Dr. Kelly, thank you.
Anthony.
Yeah, pleasure.
Okay.